Perfect. How's everybody doing this morning? Good. So my name's Chelsea Keedy. I'm originally from Massachusetts. I got my bachelor's in biology there, went to pharmacy school there as well at Western New England University, and then came to Savannah, Georgia, where I did my pharmacy residency for 2 years with St. Joe's Candler and the University of Georgia. Stayed on after that with the health system in primary care, hepatitis C management, and anticoagulation. Faculty at the University of Georgia now, and I maintain my practice site in primary care. So a lot of why I chose this topic to choose today was I do a lot of annual wellness visits in the primary care sector. So I work collaboratively with 7 physicians, have a collaborative practice agreement with them that helps us identify patients who are in need of population-based health screenings, things like that. We do a lot of vaccinations, making sure that what we're doing throughout the wellness visits also matches up with meeting quality metrics like MIPS and things like that. So if there's any questions about that, I'm happy to answer that too, but I think people are either really interested in that stuff or not, and I don't want to bore people to death with that. I think I'm having clicker issues here. Okay, do I need to point it in a certain direction?
And now you're the other way. Huh? Oh. Oh,
It was working a minute ago.
now the clicker works.
There we go. Okay.
Okay,
So in terms of objectives,
great.
it's going to be broken down into
Thank
4
you.
main sections, and then we'll have
Unable
cases
to-
throughout,
this-
and
my phone
also
said
an interactive Jeopardy game
allow
at the
Zoom
end
to
with some
access
prizes.
the
So hopefully
phone.
that'll be fun for everybody.
Go to
We're
settings,
going to talk
privacy,
about
and
pharmacological
microphones.
properties for various forms of contraception and emergency
Don't have
contraception.
what?
Take a look at specific patient cases and scenarios. For each of these topics, we'll talk about osteoporosis management, and the updated United States Preventative Task Force screenings, as well as preventative screening measures and immunization updates. We'll talk about pregnancy and lactation categories, because that was updated in the last few years as well. So that rating system and how those medications are summarized and categorized is different than it was previously. Certainly an improvement. And then patient considerations related to updated pregnancy and lactation recommendations. And if anyone has a question at any point or wants to stop and make a comment, feel free. I certainly want this to be as interactive and enjoyable for everyone as possible.
Right here.
So starting with preventative
says
medicine. So the gold standard here is really the United States Preventative Services Task Force that reviews graded recommendations on preventative health screenings related to all sorts of different things, and we'll get into those categories. So they have huge groups that meet and formulate evidence and specific recommendations for how you can apply these to clinical practice. And really, they look at a multidisciplinary approach to helping meet these quality metrics and helping patients meet the required screenings and things like that. So when we look at the United States Preventative Task Force screenings, they basically have a grading that is A, B, C, D, or I. So we're really going to focus here on this A and B recommendation stratification. I think those are the ones that are most relevant. They certainly have the most evidence. We want to make sure that we're talking about the screenings that have that moderate or substantial benefit. And as you get down, there are certain screenings that potentially cause more harm or confusion than good. So the United States Preventative Task Force website is a really great resource to kind of look at that. We continually evaluate the updates as part of our wellness visits to say, you know, are there things we're doing that are no longer graded as high in terms of evidence as they were before? And should we really be taking that out of our automatic screening measures and questionnaires that we go through with patients? So we have these measures that fall into certain categories. There are certainly some measures that fall into multiple categories, but we'll only talk about them in one. So we have a cancer recommendation that talks about colorectal cancer, lung cancer, tobacco cessation, cervical cancer, and skin cancer prevention. Cardiovascular disorders are huge, talking about healthy diet and lifestyle, statin use, blood pressure management, and blood pressure screening. Developmental and behavioral health, especially fall risk in older adults, and then infectious disease, a various variety of screenings here. And we'll focus mainly on the Hep C and the HIV screenings because of the updates and the screening recommendations with that as well. And as a pharmacist, a lot of these screenings lead to downstream pharmacy and pharmacological related treatments. So this is kind of a way to systematically go through and review those updates in the pharmacology. And then diabetes and prediabetes screening. And then there are also recommendations on osteoporosis and various OBGYN conditions, but we'll be talking in the second half about osteoporosis and women's health updates. So we'll cover those in that section. So our first recommendation is going to be for colon cancer screening. So this is a grade A recommendation. So certainly a very high level of recommendation here to be screening people age 40 to 75 at least, and some individuals even younger than that for colon cancer. About 94% of colon cancers happen in patients 45 and older. So this age-based screening is certainly really helpful in catching and capturing those people that are sometimes asymptomatic. So we have options here. The fecal occult blood tests are certainly popular and have been around for a while. There are some frustrating things about those. Depending on the test, patients might have to have dietary restrictions before or collect multiple stool samples. So the emergence of the sDNA FIT test has been certainly really helpful over the last few years. And the only one on the market is Cologuard. Has everyone familiar with Cologuard or heard of Cologuard before? So we utilize this a lot in the office. You cannot use it if patients have a personal history of polyps or a personal or family history of colon cancer. So it's not appropriate for some patients, but it's a great opportunity for a lot of patients to avoid that initial colonoscopy. Now, certainly if the Cologuard was positive, then they're going to need that follow-up colonoscopy. So you want to bear in mind, if it's someone who's absolutely never willing to have a colonoscopy, then that might not be the best choice for them. But it can be a great option for a lot of people. It's only one stool sample test. There are some false positives, but if there is a false positive, then that gets identified with the colonoscopy. So this test, similar to the fecal occult blood test, does look at the presence of blood in the stool using antibody testing, but it has that additional FIT DNA component that looks at certain biomarkers and predictors on a genetic level for colon cancer risk. So a huge issue that we used to have with these tests, I don't know if you've run into it before as well, is that insurance would pay for this as the screening, and then they wouldn't pay for the colonoscopy if they needed it because they said they already paid for the screening test. So that was really frustrating, but Medicare has changed that over the last few months, and most of the plans are now recognizing the need and will reimburse for that follow-up colonoscopy. So that's something that's changed. Unfortunately, patients would get this huge bill for the colonoscopy, and it was really frustrating for them. Okay, so our next recommendation is going to be our lung cancer screening, and then we'll go into a pharmacology review of our agents used for smoking cessation. So the United States Preventative Task Force recommends an annual screening with a low dose lung CT. So if people have a different type of CT, then that can count as this. But this is recommended yearly for patients that fall into a certain category. So this is going to be those 50 to 80 years old who have a 20-pack year history and who are still smoking, certainly, or have quit within the last 15 years. Something that is unfortunately also frustrating insurance-wise. Hate that we even have to talk about it, but I mean, it's such a dictator of everything that we do in the healthcare field. Medicare Part B generally covers the screening for people 55 to 77, even though all the recommendations are starting at age 50 and up to age 80. So I usually have that conversation with patients if they fall into either of those ranges. Hey, we may want to check with your insurance first to make sure that this is covered so you don't get a bill. But as long as people fall within that age range, this should be covered and reimbursable. So when we're looking at pack years, we want to make sure that we are multiplying the packs per day by the total years smoked. So the easiest way or example would be a pack a day for 20 years would be a 20 pack year history. But if someone's smoking 2 packs a day, it would only take them 10 years to get to that threshold. And the old recommendations were a 30 pack year history. I know that our EMR has not caught up to the updated recommendations of the 20 pack year history, but that threshold has been lowered in recent years to a 20 pack year history. And I just put here, not that you would necessarily do this in patients who are using smokeless tobacco because their lung cancer risk at least is lower, although certainly higher for some other cancers. Just keeping in mind that some of our other forms of tobacco are much more potent than cigarettes. And these are becoming popular in use, especially amongst young people. So 1 can of smokeless tobacco is 4 packs of cigarettes. So you could have a 20 pack year tobacco use history after using cans of smokeless tobacco for only 5 years. So I think that's kind of crazy and important. Education piece, I think a lot of times patients think, well, this isn't nearly as bad as the cigarettes, but in reality, it's often worse. And the Preventative Task Force, yes. Yeah, so it's hard to equate exactly what vaping would be because of the differences in the different products. There's all sorts of different, milligrams of the vaping products and things like that. I mean, the one good thing about that is they're not getting those other chemicals. It's just the nicotine component, but they're doing a lot of studies about the vapor inhalation and things like that and how dangerous that probably is long-term. I know during COVID too, the damage on the lungs in some of the young people who were otherwise healthy and got COVID but vaped was detrimental. So that's certainly a good point. And I'm not sure. I mean, I think the lung cancer risk is so much lower. I don't know if insurance would approve for a screening like this in someone who vaped. But if there was a concern, I mean, it would certainly be worth looking into with that individual payer. So the Preventative Task Force is huge on behavioral counseling as well. So we ask all patients about their nicotine use and their alcohol use as well. And then the most important thing to remember is that all the studies show that a combination of pharmacological therapy and behavioral counseling really works best when we're approaching smoking cessation. So that's important to keep in mind. It can be difficult to take the time to do that and provide that behavioral counseling. As pharmacists in the primary care sector, we do a lot of that, follow up with people, keep them on track, and try to keep them working towards meeting their smoking cessation goals. And the recommendation is a little bit different for pregnant individuals because they don't recommend that pharmacotherapy portion. So just a little reminder here of our process for smoking cessation. An easy way to remember it is your 5 A's. So you want to ask the patient about their current tobacco use, and if they did quit smoking recently, provide them that support and motivation to stay quit long-term. Advise and assess. If patients aren't willing to quit at that point, if their readiness to quit is low, then just providing them a brief message and moving on is really the best way. Patients, typically, unless they're truly ready to quit, that success rate is low. And for most individuals, it takes about 7 times to try quitting before they quit successfully long-term. So I think that's really important too, is that making sure the patients understand that a relapse in their tobacco use is not a failure. It's actually typical. I mean, most people have to kind of have that repeated cycle of understanding their triggers before they're successful long-term. Yeah. Right. Yeah. Yeah. And what I usually tell people is if they're frustrated and they're like, well, I quit smoking for, a year before and then I went back. I'm like, but you did it for a year before. Like you can do it for a year again, like even a day is a big deal. So I totally agree. Providing them the counseling and the medications and then additional resources, and then really that telephone or in-person follow-up. I found that patients really enjoy this. I think that sometimes they feel like, the system doesn't care about them and that, this isn't like that they're alone in this. So I've noticed a huge difference in just calling patients like leading up to and after their quit date, that really helps them stay motivated, and it provides accountability too. I think if they know that someone's calling them and asking them if they're still ready to quit, then they're sometimes more likely to stick with it. So using open-ended questions and non-judgmental language is really important, making sure patients feel like it's a comfortable environment where they can be honest about their triggers and, why they've relapsed or why they've continued to smoke. And then the best option is really to set a quit day within 30 days. So studies have found that that's kind of like where you have the most effectiveness in terms of sticking with that quit date, because less than 30 days, it doesn't really give them the time to prepare mentally and just things that they can do to prepare, such as if they smoke in their car, getting their car washed, if they smoke in their home, cleaning their home, getting all their, getting a deep cleaning. Doing those things may seem silly, but they're actually like really motivating to help people prepare their environment to quit. Reviewing past quit attempts. So what went wrong, what worked last time, what didn't, how can we troubleshoot that and overcome it? As well as discussing potential trigger strategies. I think it's so different for patients depending on what they're going through. I mean, that hand to mouth fixation is so huge for some people. Having like a pencil or a straw to chew on or utilizing hard candies can be really helpful. For some patients, just having 2 cigarettes in their wallet, knowing it's there, like gives them the comfort to stay quit. I've heard that a lot, just knowing that they have it if they need it. And for some people, they're like, if I even see a cigarette or smell a cigarette at all, it's done. So just understanding that individual patient is certainly important. So what are our pharmacotherapy options and how can we utilize them? So we have our tried and true nicotine replacement therapy options. So they've been around for a really long time, but they certainly work with patches, gums, lozenges, and then less commonly used are going to be our inhalers and our sprays. And then we have our oral medications, bupropion, and then varenicline, otherwise known as Chantix. So the combination of a long and a short acting product is certainly preferred. So a patch and a gum or a patch and a lozenge, for example. A lot of times people have tried one or the other, but never both together. And then that being said too, there are studies that have shown a benefit with Chantix use in combination with nicotine replacement therapy. There are studies that have shown benefit of Chantix use in combination with bupropion as well. So if somebody is already on bupropion, maybe it's for another condition, for a mental health condition, and they want to try Chantix for smoking cessation, you certainly can add that agent on. There are no studies that have shown it's been looked at, but the benefit hasn't been seen with bupropion and nicotine replacement therapy in combination. So that's kind of the only combo we're not really sure if there's any benefit to doing that. So a little bit of review of our different replacement therapy options. So I think most commonly we have the gum and the lozenge. The gum is up to 24 pieces a day and the lozenge is up to 20 pieces a day, and they come in 2 and 4 milligrams. And you want to decide which one to use based on when the patient has their first cigarette. So if it's greater than 30 minutes after awakening, then they need that lower dose. So the 2 milligrams would be appropriate. But if that first cigarette is within 30 minutes, then they likely need that higher dose of 4 milligrams. So we use the Fagerstrom scale to look at their dependence to nicotine, and we use that as well to help decide maybe what strength we would use in that particular patient. It can be really helpful to understand not just, when they smoke, how much they smoke, but also like what events throughout their day trigger the most nicotine use. So you want to use caution, especially with the gum in patients with TMJ or dental work. That makes sense. And then just remembering how the gum works. So the patient should chew the gum until they feel that tingly feeling using the chew and park method. Park it in their cheek until that goes away. Once it's no longer tingling, then you chew it again until the tingling comes back. Then you switch it to the other side and you repeat that process until there's no flavor left in the gum. So the point of the lozenges and the gum is to replace those cigarettes. So the best thing is really to have the patient put on that patch once every 24 hours, wear that patch throughout the day, and then use the gum or the lozenges when they would have those additional cravings. And I found it can be helpful to kind of set even a detailed plan about, okay, well, how many pieces of gum are you using? Let's have a plan to like decrease that every few weeks. And you can patients get terrified, although it's not ideal, you can smoke on the patch or with the gum. So if they have, a relapse and they have a cigarette, it's okay. It's not the end of the world. They can, work through it and continue on. So if you think about like someone who smokes a pack a day and the total nicotine that they're getting from that compared to what they're getting from the patch if they smoke a cigarette, I mean, it's not ideal, but it is still safe. So then we have our patch. Typically you'd wear the 21 milligram patch for 6 weeks, the 14 milligram for 2 weeks, and then the 7 milligram for 2 weeks and taper off of that. If they need to wear it for longer, that's okay. This is just kind of the standard decrease in dose of the patch. If they smoke 10 cigarettes or less, then you can start at the 14 milligram patch. So the nasal spray, I would say this is used the least, but I wanted to put it on here for comprehensiveness. You can use up to 40 sprays a day. You want to be careful in reactive airway disease and sinusitis. The inhaler, has anyone seen the nicotine inhaler? Yeah, it's interesting. So we've had patients have a lot of success with this. We certainly don't use it commonly, but for the people that really have that strong hand to mouth fixation and correlation, this can work really well for them. So I think it's just a less commonly utilized option. Is it? Everything's on manufacturer back order right now. It's crazy. So frequent continuous puffing for up to 20 minutes. So it really takes that place of the cigarette and kind of provides them that same experience as the cigarette. That being said, even in patients who smoke a pack a day or more, they say at first when they use that inhaler, it's like, it really kind of jolts you. So just warn them about that. Like it can be kind of surprising, even to a long-term smoker, how intense that inhaler use can be at first. And it comes in a little cartridge. I mean, it pretty much looks like a pack of cigarettes. So it's kind of interesting. All right, so let's get into our oral agents. So bupropion, typically for smoking cessation, is going to be 150 milligrams by mouth daily. You can increase it to twice daily after that. There are hepatic dose adjustments. We want to be aware of drug interactions, especially with MAOIs. And our biggest thing with bupropion use in general, regardless of the indication, is that we do not want to use this medication in patients with a history of seizure disorders. Chantix, there are renal dose adjustments for it. It is certainly a game changer. It's the only one on the market that works the way that it does. So varenicline competitively binds to the nicotine receptors. So when patients smoke on Chantix, they don't get the same pleasure from smoking that they would because that dopamine can't be released. So a lot of times patients will just be disgusted with cigarettes, even though they were highly addicted before, once they start taking Chantix, because that pleasure loop, which is what causes the addiction with smoking cessation, is now blocked. Because we have that blocking, but still some release of dopamine from the varenicline binding, we also see that those withdrawal symptoms are not as bad. So when patients are using the patch or the gum, those withdrawal symptoms, anger, frustration, all of those things can be really intense for them and their family members, certainly, they often say. But this kind of avoids that. So it is a great option. I think that there are some thoughts about Chantix. It was controversial for a while. Initially, there were black box warnings for cardiovascular and neuropsychiatric events. The Eagles trial was conducted, and that warning has since been taken away. So just be aware that that black box warning is not there. You can use Chantix in these populations. You may still want to be cautious. I mean, the side effects in terms of really abnormal dreams, and some mood changes can be pretty severe in some patients. So patient specific, you may still not want to use it, but that black box warning is gone and it has been found to be generally safe. The biggest issue with varenicline besides the dreams is the upset stomach. That's why you can see here that there's a dose titration. You start pretty low and then you get up to that target dose of 1 milligram twice daily. So if patients take this with food, that can really eliminate that. We've found that patients have the most success if they take it with breakfast and with lunch. So that being said, because they are getting it with food, it decreases the GI upset. And then if they take it with lunch a little bit earlier in the day, then oftentimes they can avoid those abnormal and strange dreams as well. So we've had a lot of success just having that second dose be given a little bit earlier in the day. So the recommendation is to start 1 week before the quit date. A lot of times patients are ready to quit sooner because that blocking of the dopamine pathway is so strong. If they are not ready to quit within 1 week, that's okay. They can really start anywhere they can really quit anywhere within that starting pack, and it's okay. That can be a huge stressor for people. I have to quit on this day. I'm not ready to quit, so I don't want to start taking Chantix because I don't feel ready to quit in a week. But that's not really the case. You mentioned back order issues. It has been a huge problem with Chantix over the last year. There were manufacturer recalls. It has somewhat resolved, but I still have patients that say they're unable to get it. So just keep that in mind. But insurance coverage has gotten really good for varenicline, so that's exciting. Breast cancer screening. This used to be a yearly recommendation, and now it's every 2 years. So this is for women age 50 to 74, has the greatest grade of evidence in terms of breast cancer screening. We have a lot of patients in our office that still get yearly mammograms. I don't know about y'all, and I've never seen insurance push back on it. But that screening is every 2 years if you're more comfortable and a patient's willing to go every 2 years. I also wanted to put here for women at an increased risk of breast cancer, 35 and older, there is a recommendation to prescribe our raloxifene or other aromatase inhibitors to prevent breast cancer. I think this is something that's really interesting. There's a lot of considerations. There's various screening tools. There's no absolute cutoff of when you should use these medications, at what risk and what screening tool. If someone has a really strong family history, BRCA mutations can increase someone's risk of getting breast cancer, and their overall risk can become as high as 72%, which I mean is crazy high. So I just wanted you to be aware that there is evidence and a recommendation to actually use these medications for the prevention of breast cancer if you feel that that's appropriate for a patient at certain high risk. Okay, so the new updated cervical cancer screening guidelines are for cytology every 3 years, women age 21 to 29, and then women that are older age 30 to 65, you can do every 3 years with cervical cytology or every 5 years with HPV testing. And then I put the skin cancer recommendation in here as well. It's specifically for children and young adults, especially for those with fair skin. But certainly, this can be helpful for everybody to keep in mind. The FDA states the best way to avoid skin cancer through sunscreen use is using at least an SPF of 15 or greater that protects against both UVA and UVB rays, and then providing continuous education on the dangers of indoor tanning. Any questions before we move on to cardiovascular health or comments or anything? And I think it was yesterday that you had the cardiovascular speaker. What did you say? Oh, opioids yesterday, cardiovascular tomorrow. So I won't get too much into this, although I know some people won't be here tomorrow. So The United States Preventative Task Force recommends statin for primary prevention if you have one or more risk factors: dyslipidemia, diabetes, hypertension, and a 10-year ASCVD risk of 10% or greater. I put this in here because we're going through the Preventative Task Force recommendations, but I think the gold standard for statin use is really ACC-AHA, and that's different than the recommendations from the Preventative Task Force. So certainly be aware of that difference. These guidelines were updated in 2019. So just a review of those: who should be on a statin. LDL of 190 or greater, that's kind of independent of any of these other things. If patients have an LDL of at least 190, then they should be on a statin, ideally a high intensity statin. Diabetes 40 to 75, a moderate intensity statin. If they have what the new guidelines call risk modifiers, then you can consider a high intensity statin in these people. So one of those things is long duration of diabetes. You'd want to consider a high intensity statin. And then age 40 to 75, we still have our recommendation based on ASCVD risk score. If it's 5 to less than 7.5%, you want to kind of consider those risk enhancers. It's like the borderline group for statin use. If it's 7.5 and above, then you really need a statin at that point. So at least a moderate intensity statin. If they have other risk enhancers, probably a high intensity statin. And this 20% or more group absolutely need at least a moderate intensity statin, but likely all of those individuals should be on a high intensity statin. And that's certainly a really high ASCVD risk score. So I just wanted to point out the difference between the Preventative Task Force and the AHA guidelines. I think the AHA guidelines certainly are a little bit more detailed and encompassing of those patients at the highest risk. And then I'm sure that you'll get into this a lot tomorrow as well, but there are also new recommendations for LDL goals and patients who have already had an event. So I think that's certainly going to increase PCSK9 inhibitor use and things like that to really get those patients' LDL down. If patients have had an event, they have the best outcomes of preventing a repeat event if their LDL is kept under 70. And for patients at very high risk, so having a major ASCVD event or an ASCVD event with other comorbidities and things like that, they're now thinking that an LDL of less than 55 is probably most appropriate for those patients. And oftentimes statin use, unfortunately, just doesn't get people there. So those PCSK9 inhibitors are great. The PCSK9 inhibitors do have an indication for primary hyperlipidemia. So if you do have a documented LDL that was ever over 190, I've had a lot of luck using that lab value to write appeal letters and get Repatha approved through the insurance for these patients. And these are those ASCVD risk enhancers that may cause you to bump up from the baseline recommendations in terms of your intensity of statin use. So premature ASCVD in a family member, a high LDL. Remember, 190 or more would automatically indicate high intensity CKD, premature menopause, persistently elevated triglycerides. And then you can also consider using a coronary artery calcium score. We don't typically use this a lot in my primary care office. Sometimes we see patients that have it done that are referred out to cardiology, but this is going to look at the calcium buildup in the arteries and look at their risk for an event. So 0 is low risk, 1 to 99, big range, but that shows that there's a moderate risk and it favors statin use. 100 or more is a really high calcium artery score, so they should certainly be on statin therapy. I think patients are still really hesitant to use statins. So sometimes the score can help them understand it from a different angle because it's based on imaging versus these risk score calculators, and can help motivate them to maybe try a statin when they weren't willing to before. So the Preventative Task Force does recommend blood pressure screening in all adults with an office blood pressure measurement, but also they recommend follow-up blood pressure screening with patients at home to get those home readings and really confirm hypertension before treatment is initiated. So I think the most important piece here is that additional home monitoring recommendation. All right, so diet and exercise, there's a huge push in all of these disease states to counsel patients on diet and exercise. What does that look like? So a healthy diet is defined as a balance of variety foods, increasing your vegetables, your fruits, your lean meats, and watching out on high fat foods, high sugar foods, high carbohydrate content. And then our activity recommendations are going to come up over and over again. So at least 150 minutes of moderate intensity exercise or 75 minutes of vigorous exercise a week with at least 2 days of strength training. That's a lot. I'm like, I try to go to the gym 3 days a week. I try to be good and I add it up in my head and I'm like, I cannot make this metric here. I mean, this is a tough metric to beat, but this is the recommendation. When I was preparing this presentation, my mom is a physical therapist and my stepdad is a dentist. So I was going over the material with them, and my mom as a physical therapist was very happy to see this. My stepdad was disappointed that the Preventative Task Force does not recommend routine dental screening. Not that it's not important, but not a recommendation within their scope. So along with the smoking screening for lung cancer, we also want to do a AAA screening to screen for abdominal aortic aneurysms in patients who are smokers. This is a little bit different. Remember that low dose lung scan was patients who have at least a 20-pack year history and who still smoke or who have quit in the last 15 years. This is and that's yearly. This is a one-time screening, men who are 65 to 75 who have ever smoked. So it doesn't matter when you quit, even if it was 30 years ago, if you're a male within this age range, you should still have this screening. And not that the screening can't be done at other ages or in women, but this is the group with the highest level of evidence that's at that highest risk. Okay, so moving on to behavioral health. So we recommend screenings for all adults for drug and alcohol use. And there's an asterisk here that this screening is focused on asking questions and understanding illicit substance use, not focused on providing urine and drug screenings. So they're not recommending that you routinely test everyone's biological specimens. This just that you do questionnaires to identify risk and use, and if necessary, provide that behavioral counseling piece. So we use the Audit C for alcohol screening. It provides questions about how much do you drink in a setting. It screens for binge drinking and things like that. The threshold is pretty low for how someone can identify as positive, but it can be helpful for identifying patients that may be at the highest risk and need that additional behavioral counseling. So all adults should also be screened for depression and suicide, including pregnant and postpartum women, certainly. And then, if necessary, appropriate follow-up should take place. And we use the PHQ-9 in our office for depression. We used to use the PHQ-2. The PHQ-9 is a little bit more comprehensive in the questions that it asks. So who might be at higher risk for depression? Women, undereducated individuals, previously married individuals, people with chronic illnesses. And then these risk factors are a little bit different in our older adults. So disability or poor mental health or physical status, chronic sleep disturbances, loneliness, or a previous history of depression prior to them being at that older age. So these are some examples of other tests that are commonly used. There's no recommendation for how often these screening tests should be used. We just use the PHQ-9 every time they come in the office, whether they're seeing the physician, the nurse practitioner, the pharmacist. If they're in the office, we're using the PHQ-9 score. If they score a high score, there's moderate, and then there's kind of severe. If they even fall into that moderate range, we're following up and making sure that they have that follow-up behavioral health component. I think it's important to, we utilize our MAs and our CNAs a lot to do these questionnaires, and the PHQ-9, I mean, it's 9 questions. It can be time consuming to ask, but a lot of times what ends up happening is a patient just gets asked, have you been feeling sad or depressed lately? And if they say no, then all these questions get marked as no, and it's not really an accurate predictor or use of how they're feeling. So it's an important education piece too, to support staff utilizing the questionnaires, that they know to really take the time to answer these questions and go through them with the patients. In terms of screening for infectious diseases, adults and adolescents at increased risk should be screened for syphilis, for Hep B, for STIs, and latent tuberculosis. I want to point out here that the recommendation for chlamydia and gonorrhea screening is all sexually active women 24 or younger, and women 25 or older at increased risk. I think that's something that probably gets missed a lot in these women 24 or younger, but this is kind of an across the board recommendation regardless of their other risk factors. All right, so we're going to spend some time on the updated recommendations for screening for hepatitis C infection and for HIV as well. So the screening for HCV for a long time was based on risk and it was based on age. When I started working in the hepatitis C clinic, that's what it was. So we were screening our baby boomers. You know, the baby boomers need to be screened. But these new recommendations, and this is not just the United States Preventative Task Force, this is the CDC as well. And the CDC is even more all-encompassing. They say all adults. So at least adults 18 to 79, but probably all adults should be screened for hepatitis C at least once in their life. Certainly, if they have risk factors, they should be screened more frequently, often yearly, but no matter what, people should be screened at least once for both Hep C and HIV. And I think this has not been commonly widely adopted yet. These new recommendations aren't kind of, I guess, been implemented on a wide scale the way you would hope. So the initial screening for hepatitis C is going to be either detectable or undetectable. If that antibody screening is positive, then you want to move on to that RNA screening. And that's what would help you decide whether or not they had active Hep C infection. It's an important education piece to the patients as well that we treat within our Hep C clinic, that antibody is always going to be positive. So even if you're treated and these treatments are curative, which is awesome, that antibody is always going to be positive. It's the RNA that is that predictor of an active Hep C infection. And some patients do self-clear. So that's the other possibility. If someone has a positive antibody and their RNA is negative and they're like, I didn't even know I had Hep C, I've never been treated. We don't know exactly why, but some patients are able to self-clear the virus, which is pretty remarkable. So patients should be informed that they are being screened, what the different tests mean, and what the treatment options are if that test is going to be positive. That linkage to care piece is really important. Having that set up in place, an automatic referral process to get them hooked up with a clinic that's going to help them get the medications affordably is really important. So the best way to do this, and this is the same recommendation for HIV, is to utilize opt-out screening. So the patient has to be informed that they are getting the test, but it doesn't have to be a signature from the patient. It can even be in the hospital's general consent. So we looked at, there's a lot of companies that will support and fund automatic screening to get institutions on board with these updated guidelines. We were like right on the cusp of doing it at my institution, and then COVID came like the week that we were supposed to roll it out. So that really put a halt on it for us, but we were going to screen, the best way to do it is to screen all patients that come in through the emergency department. We were going to start with admitted patients just to kind of start a little bit smaller scale, but the company we were working with for the funding said the best way to do it is to really have it in your general consent. Let them know that we screen all adults for Hep C and HIV. You're giving them the opportunity at that point to not sign the consent, and that's opt-out screening. So it's certainly different from the old recommendations and requirements that you needed a signed waiver to be able to provide someone an HIV test. So a reminder about the DAAs, they are curative. Nearly all patients with a positive Hep C antibody should be offered these medications. So I think a few other common misconceptions are that patients with current alcohol or IV drug use should wait to be treated for Hep C, and that's not the case. You should provide them counseling on safe transition practices, but then start the direct-acting antiviral agent. This excludes pregnant women, so that's different with HIV treatment, but with Hep C, the recommendation is to wait until the individual is no longer pregnant to start the hepatitis C treatment. And the treatment is generally 8 to 12 weeks in duration, depending on the agent that you choose. So also in COVID, a lot of places stopped doing genotype testing for Hep C because the pan-genotypic agents worked so well. So an uncomplicated hepatitis C, that pan-genotypic treatment, both Mavyret and Epclusa are options. Does anyone do like 340B stuff here? So, okay, so I've heard some clinics that really prefer Epclusa over Mavyret because you can get 340B reimbursement off of an additional refill because it is 3 fills rather than 2. Mavyret is 3 pills, like they're really big, and you have to take the 3 pills once a day. So for some patients, Epclusa might be better because of that. But I mean, from a patient standpoint, the Mavyret is 8 weeks. So just keep that in mind. The Mavyret does have to be taken with food. Epclusa does not. If Mavyret is not taken with food, then it can really cause a lot of GI upset. Okay, so moving on to HIV screening and PrEP. So we talked about this in terms of the opt-out screening with Hep C, and it's really the same for HIV. And if you look at here, the cutoff is a lot lower. We should even be screening those starting at age 15. And some recommendations, it says 13, that they should get that one-time HIV screening. And a big point of these new recommendations is not only because they found that by only screening people at certain risk or at certain ages, you were missing so many individuals, but also these screenings reduce and prevent the stigma around it. So, it doesn't matter who you are, you should be getting an HIV test. Persons at risk for HIV acquisition should be offered PrEP or pre-exposure prophylaxis with antiretroviral therapy or ART. Just a little bit reminder of HIV screening. So the initial screen is with an antigen antibody test. If it's reactive, then you should do supplemental testing to differentiate between HIV-1 and HIV-2. If it's non-reactive or indeterminate, the recommendation is to proceed to an additional HIV-1 nucleic acid test to really figure out if they have HIV or not. Sometimes if they were recently exposed, there might be a delay in them having a positive test. Very similar recommendations to the hepatitis C screening. We want to make sure that patients are aware of the test, what the result means, and linkage to care. So the best thing to do is if it's on the inpatient side and they're being informed of that positive result, at that point to get them set up with an appointment somewhere and link them to care before they even leave the hospital. So they have that in place. That's really a game changer in terms of people being adherent to attending their appointments. Provide them an opportunity to ask questions. So unfortunately, unlike our agents for hepatitis C, there is no cure or vaccination that exists for HIV treatment, although these medications have certainly come a long way. Studies have shown that when ART is used appropriately, it leads to suppression at levels that make the virus not transmissible. Pregnant women should be started on ART. This can drastically decrease the risk of transmission to the newborn or the fetus. And then we also want to discuss prophylaxis for opportunistic infections when indicated, immunizations for patients with HIV, and screening for certain cancers. Moving on to PrEP, I think this is something that is growing in terms of clinics that focus on PrEP, especially in the 340B world. So men who have sex with men and heterosexually active persons are not considered high risk if they're in mutually monogamous relationships. So I think that's an important key piece here. And patients who are being considered for PrEP should have a recent negative HIV test, because if that HIV test was positive, then at this point, it's not PrEP, right? So who should have PrEP? So people who are heterosexual or men who have sex with men should be considered for PrEP if they have one of the following characteristics. If their partner has HIV, if they have inconsistent use of condoms during certain types of sex, if a STI was transmitted within the last 6 months. So really, regardless of sexual orientation, these risk factors are indicative of PrEP being utilized. So if a person injects drugs and has one of the following characteristics: shared use of drug injection equipment, or a risk of sexual acquisition of HIV, then these individuals should also be on PrEP. So the screening is really huge, and I think it's unclear where the screening should take place to identify, patients that meet these criteria to receive PrEP. I don't think that it's something that's routinely done or consistently done across a variety of settings. So what are our options for PrEP? So we have emtricitabine in combination with tenofovir, and it's 2 different formulations. So the first one is going to be Truvada. That was the first one on the market. And then more recently, Descovy has been approved. So Descovy is more bioavailable at lower doses, so it tends to be better well tolerated from a side effect standpoint for patients, but it is not approved for women or for that drug use transmission. So depending on what their risk factor is, you may still end up using Truvada, but Descovy can certainly be a more tolerable option for some patients, and it has shown to be safer in renal and bone disease. The Preventative Task Force does recommend that vulnerable women are screened for intimate partner violence, and that we are screening our older adults for fall risk, especially those that have risk factors that may be indicative of a higher fall risk. So issues with balance, impairment, we do all this as part of our Medicare wellness visits as well. We do a fall screening questionnaire, ask them about, do you have grab bars in your home if you need them? If not, we try to get them connected with installation of grab bars, making sure that they are able to do their ADLs at least somewhat by themselves and that they're comfortable with their living environment. So if there's any concern, then certainly patients should be hooked up with an opportunity to get grab bars or other assist devices or types of social help as well. And again, this physical activity recommendation comes up. So at least 150 minutes of moderate intensity, 75 minutes of vigorous intensity, and that strength training at least 2 days a week. So screening for diabetes and pre-diabetes, who should be screened? So we should be screening to patients who are 35 to 70 who are overweight and obese. And for those with a BMI of 30 or higher, then we should be also providing those behavioral interventions or components as well. So screening frequency is not well defined. How often should somebody be screened for diabetes if they are at higher risk? I think most typically they would just get it on their yearly labs, but it really depends on what the provider's preference is. And then just remembering our glucose and our A1C cutoffs. So that fasting of 125 or an A1C of 6.5 or greater would be consistent with the diagnosis of diabetes. And preventing progression from pre-diabetes to type 2 diabetes. So lifestyle interventions, again, diet and physical activity. Metformin has been shown to have some benefit in patients that have pre-diabetes to prevent the progression to diabetes, but it is not FDA approved for that indication. So just be aware of that. And then controlling other comorbidities is huge. I think it's unfortunate that some of these agents, the newer GLP-1s that we're seeing that have a weight loss indication, I wish they had a pre-diabetes indication to kind of prevent some of these patients from, going over the edge into that diabetes range. We have had patients that are right over the line, like with an A1C of 6.6 and that want to lose weight. And that is a great opportunity to get them one of the GLP-1s for an approved indication. While those shortages are a huge issue with the GLP-1s, I mean, we are just running into that every day. It's changing which GLP-1s we can get for our patients and which ones we can't. Yes. It's supposed to be a sustained loss. I think that the agents are so new that it's hard to say what that's really going to look like long term. And if patients have diabetes, then they're likely going to be on it continuously. But I have had patients who have been on the approved options for weight loss, so either Wegovy or Saxenda, and they have been able to maintain that weight loss since stopping the agents. So it's certainly different than like, phentermine or something like that, where as soon as you stop, it's like this huge drop off to where a patient was before. So it is more sustainable because of the way that it works with those satiety hormones. It is a more long lasting effect and reshaping how they kind of think about food on a physiological level. So that's a great question. All right. So we are going to move into our assessment questions for this portion. So EL is a 45-year-old female with a past medical history consistent of hypertension. She does not drink alcohol, but admits intermittent IV drug use over the last 15 years. She last used IV drugs 2 weeks ago, and her labs are within normal limits, except for her Hep C antibody, which is positive. So which of the following treatments is best for EL? Yeah, absolutely. So we have to do a RNA test to make sure that she truly has Hep C. But if she does, then there is no need based on her social history to wait to treat. She should be treated pretty immediately. Okay, so we have a 68-year-old male with a 20-pack year history who quit smoking 20 years ago. Which of the following is most appropriate for him in terms of lung cancer screening? So it's going to be B again. So he falls into the age range for AAA screening, and that's regardless of how much tobacco you use or when you quit. That yearly lung cancer screening, remember 20-pack year history, yes, he meets that, but he quit 20 years ago, and it's someone who either currently smokes or who has quit within the last 15 years. So just a little bit of a caveat between those two screenings. All right, and which of the following recommendations is appropriate for most adults in terms of physical activity? Yes, A. All right, any questions about this section? Try to break it up here into different sections. Okay, we can take a little break now if y'all want, if you need to use the restroom or anything.
Yes.
Oh, perfect. Okay, we can take a little break then and do that.